My name is Tom Sarley, and today I'm going to talk about the relationship between distance travel to hospital and outcome following emergency laparotomy. The context for this analysis was the ongoing reconfiguration of acute care. In recent years, many clinical services, for example, stroke, vascular surgery, and trauma, have been either reconfigured or centralized into high-volume centers. And there's an argument to do the same for emergency laparotomy care. The NELA reports have found as a recurring theme considerable variation between hospitals in terms of case volume, also structures and processes of care, and in risk-adjusted outcomes. And one way to address this would be to concentrate care in specialty centres. Another consideration is the relationship between elective and emergency care. A recent analysis found that the factor most predictive of the cancellation of elective treatment was the presence of an emergency department. But before we consider any benefits of reconfiguration, we need to think about the risks. And one of those is that reconfiguration will increase the distance some patients travel to receive care. And that was the subject of this analysis. In this study, we explored the implications of patient travel on emergency laparotomy. The effect of patient travel has previously been studied for a number of medical and surgical conditions, both elective and emergency, and results have been mixed. Some studies have found a distance decay effect, which is worsening outcomes with increased travel time. However, some studies have found either a distance bias effect, which is improved outcomes with increased travel, or no effect. And this has not been previously studied for emergency laparotomy at a national level. In this analysis, we used the NELA dataset, which is the largest and most comprehensive of its type currently available. Our aims were to describe the distances that laparotomy patients travel for surgery, to describe the characteristics of patients and hospitals stratified by distance, and to investigate the relationship between patient travel and short-term mortality. Our hypothesis was that since often laparotomy patients have time-critical pathology, any delay would be associated with worse outcomes, and that patients who take longer to reach hospital would have increased mortality. I wanted to frame the context of our analysis by also including some comments from a laparotomy patient who gave input to our study. The patient was treated at his local hospital and said that this was important to him, but also to his family who were visiting him during the course of his surgical admissions. He commented on the importance of high quality care, and he also described frustration at the referral phase, and this highlights that access to care is related to several factors beyond distance to hospital and travel time. The exposure variable in our study was travel time to hospital, and we estimated this based on an assumption, which was that patients travelled from their home address to hospital before having emergency surgery. In the NELA dataset, patient home addresses are aggregated into census areas called LSOA, and our calculations were based on travel from the population-weighted centroid to hospital using an on-road calculation without any traffic effects. And then we used our estimated travel time variable in both descriptive analysis and subsequent modelling. At the time of analysis, we had data for 171 hospitals that accept emergency general surgical patients. These centres are displayed on the map with the background shaded by distance to hospital. And one initial observation is that by international standards, the distances to hospital are relatively small, and most patients in England and Wales live relatively close to a hospital. Since both population and hospitals are clustered in urban areas, many patients live in proximity to multiple centres, and this is significant if hospitals are reconfigured into network arrangements. We looked at the baseline patient characteristics stratified by distance to hospital, and we found that older patients live on average further from hospital, whereas areas of socioeconomic deprivation in urban areas tend to be closer to hospitals. We looked at hospital characteristics stratified by distance to next closest hospital and found that more remote hospitals are likely to be smaller in terms of bed numbers, have lower laparotomy case volume, and are less likely to be designated as tertiary gastrointestinal surgery centres. We focused our analysis of travel time on patients who had either urgent or immediate surgery. This included almost 23,000 patients who had surgery between 2013 and 16, and we found that the median patient lives 8.4 kilometers from the hospital at which they underwent a laparotomy, corresponding to an estimated median travel time of 16 minutes. By point of comparison, these patients had a corresponding in-hospital time before surgery of greater than 12 hours. We wanted to know whether travel time has a relationship with short-term mortality. On this graph, you can see estimated travel time in minutes on the x-axis and 30-day mortality on the y-axis. Each of the scatter points represents an equal number of patients, and you can see that the scatter points are clustered on the left side of the graph, indicating that most patients have relatively short estimated travel times to hospital. We know that patient characteristics do vary with distance to hospital, and so next we used estimated travel time as a variable in adjusted regression models to look for any independent effect of travel time. We found no effect of estimated travel time on short-term mortality. In this table, we present odds ratios for risk of mortality per 10-minute increase in travel time. We separately analysed patients by surgical urgency of either urgent within 6-hour or within 2-hour procedures, and in the presence of the confounders listed below, we found no significant effects for either 30 or 90-day mortality. In this analysis, we're unable to prove the absence of any effect, but the small effect sizes suggest that if any effect exists, it's likely to be small, especially in comparison to other risk factors identified in previous analyses. I've included the citation for our study here in case you would like further details of our analysis. In summary, we described the estimated travel of patients before emergency laparotomy and found that most patients in the NELA dataset have short estimated travel time, particularly in comparison to the time that patients spend in hospital before their surgery. We described the population and hospital distribution and found that a significant proportion of the population live near multiple hospitals, and this is of relevance to any possible service reconfiguration. We looked at the relationship between patient travel and outcomes, and we found no effect of travel time on short-term mortality.